Hello and welcome. My name is Usman Sheikh and I head up the marketing department at Agafa Pharmaceuticals. Firstly, I hope everyone is in the best of health, and for those who have been ill recently, we wish you a speedy recovery. The topic for tonight's webinar, Herpes Simplex Virus Keratitis, will be presented in two parts. Part 1 will focus on manifold manifestations, and Part 2 will look at diagnosis and management. This brings me on to introducing our esteemed speakers. We are very fortunate and grateful to them for making this evening possible. Part 1 will be presented by Professor Harminder S. Dua, CBE, Chair and Professor of Ophthalmology at the University of Nottingham, UK. Part 2 will be presented by Professor Dalia Said, Consultant Ophthalmologist and Cornea Specialist at the Nottingham University Hospital, UK. Once again, thank you for joining. Professor Dua, over to you.
Well, thank you very much for that introduction, and warm welcome to all our speakers, of course, our speakers, my co-panelists, and to all the delegates who have taken the time out to listen to us. Now, we hope that this will be informative, instructive to all of you. We try to keep it as simple and as simplex as possible. So, like Osman said, it's in two parts. The first is on clinical manifestation, which I'll be talking about, and then diagnosis and management. So I'm going to start off with clinical manifestations. These are my declarations of interest, but none are directly related to the content of this talk. And this is my outline. I'll give you a very brief account of the epidemiology, give you a whole lot of illustrations of the clinical signs and an account on the basis behind those clinical signs, the epithelial changes, the subepithelial lesions, stromal changes, vascularization, endothelial involvement, uveitis, keratouveitis, and retinitis. This is looking behind the cornea. And then some of the masquerade presentations that may mimic HSV, or HSV might mimic them, and about neurotrophic keratopathy. A very brief account in a couple of slides about the corneal innervation, because simplex virus is predominantly associated with the nerves and a very high affinity to these nervous tissue. So from the trigeminal ganglion, we have the ophthalmic division of the trigeminal nerve, which gives us the two long posterior ciliary nerves and the short posterior ciliary nerve, which enter the eye around the optic nerve. The long posterior ciliary nerves go in the subchoroidal space, that's the space between the choroid and the sclera, all the way to the cornea, where they form a pericorneal plexus of nerves, which are predominantly vasomotor. From there, they enter into the cornea. So this is a brown-colored acetylcholinesterase stain of the nerves as they enter the limbus. They may enter a single large trunk and divide into two, or come in as two trunks. Then they travel in the stroma and then move to the sub-Bowman's zone in the anterior stroma, as you see here. They pierce the Bowman's membrane and end in these terminal bulb-like structures, which we discovered in 2009. And from there, these neurites arise, and these bulb-like structures can be up to 6 or 8, as you see here. And this subbasal plexus of nerves that arises from these neurites, they travel in a coronal plane along the cornea, in the subbasal part of the cornea, and then vertical elements from there rise straight into the epithelium to terminate intraepithelially or interepithelially. This makes the cornea the most sensitive structure in the human body, 40 times more than the dental pulp. You see 100 times more sensitive than the conjunctiva, and 400 times more than the skin. Very briefly, these nerves serve two functions, sensory and trophic. The sensory function serves the pain and the protection and lacrimal secretion, but the trophic function is, just as the nerves release neuromediators that provide nutritional and health-related, quality-related support to the epithelial cells and keratocytes, the keratocytes and epithelial cells produce substances called neurotrophins, which help the growth of the nerves, their regeneration, and the health. So there's a very mutually supportive role they play, and the cornea survives and functions because of the trophic and the sensory functions of the nerve. Now, we all know that the cornea is avascular, but it has to respond to injury by inflammation, and that inflammation and the inflammatory cells come from the pericorneal plexus, which is triggered by the nerve. So any little lesion you have in the center of the cornea, for example, a little erosion or an ulcer, immediately by local axonal reflexes, these vessels dilate, allow the extravasation of cells to come and fight the infection. So that is a very important part of the host defense response. Now, we're going to start with two questions, and I want you to take your polling things on and answer the question. The clinical sign of dendritic ulcer is seen in herpes zoster, herpes simplex, healing corneal abrasions, acanthamoeba infection, or all of the above. You have 30 seconds. Okay, so let's move to the next one. Active replicated herpes simplex virus is present in epithelial cells in dendritic lesions, epithelial cells in geographic lesions, keratocytes in stromal keratitis, endothelial cells in endotheliitis, or all of the above. Again, 30 seconds begin now. Okay, so thank you very much. So we move on now, and we'll come back to these questions right at the end. So by way of epidemiology, 60% of children by the age of 5 have the herpes simplex type 1 infection. Not in the eye, we're talking about in the body, so they are seropositive. 6% of them will only have the primary herpes simplex disease, and less than 1 of them will have primary ocular disease. So you can see that the virus is very prevalent in nature, but the ocular manifestation infections are less. Clinical classification is as follows. We talk about primary neonatal infection. So the child gets infection in the uterus and then develops an immune response to the virus in the uterus. So this is extremely rare. Then you have primary infection, which is in children and adults. They're usually naive, which is non-sensitized individuals. And then you get recurrent infection, which is in people who are sensitized. So if you look at primary neonatal, obviously the baby in the womb is going to be non-immune, not exposed to the virus, but they get it. And then you will find that 80% of this is type 1, which is the ocular herpes, and 20% is the type 2, which is the genital herpes, and is associated with significant mortality and morbidity. The lesions can be acute in the lids, in the conjunctiva. Cornea can be in the form of punctate keratitis, microdendrites, or elongated snake-like or lesions of dendritic, also called serpiginous lesions. The stromal keratitis indicates intrauterine infection. So if a child in the neonatal period gets stromal keratitis, it means that the infection started earlier on, so that they developed an immune response, and the stromal response, as we'll see, is mostly an immune response. So when we look at the primary ocular infection in a non-immune host, again, the same feature. Every structure of the eye basically can be involved. You can get the lids, the conjunctiva, get follicles or papillary reactions, and if it's severe, you get pseudomembranous reaction. The keratitis, again, the same thing. You get punctate keratitis, microdendrites, pretty obvious dendrites. You can get a very diffuse epitheliopathy sometimes, which is atypical in the presentation of herpes simplex disease. You do get significant skin involvement in the term of vesicular and hemorrhagic eruptions around the eye, and these usually heal with no scars, unlike, let me see, with smallpox. You used to get a lot of scars, but these don't. So this is an example here of microdendrites, little stellate lesions on the cornea in the child. And these are an example of primary herpes. You can see this rash around the eyes. It can be hemorrhagic along the lips. And this is a skin manifestation. And then you see this vesicular lesions on the lids and a number of follicles in the conjunctiva. Now, when you talk about recurrent, like I said, the patient has had the primary, that has recovered, and now they've got a second exposure, usually not from the environment, but from the virus coming down from the trigeminal ganglion. And these manifestations now in a background of already sensitized individuals is slightly different. So again, you get blepharitis, you get conjunctivitis, and the keratitis that we are most concerned with can be epithelial. And here you get dendritic and geographic lesions. And dendritic lesions and geographic lesions indicate active infection and active viral replications. And the neurotrophic keratitis is non-infective, predominantly affecting nerves, and you will see that often when you see them in the stroma, that's also non-infective. So again, recurrent virus infection, rose Bengal stain, which we don't use nowadays, you get stellate lesions or dendritostellate lesions, large dendrites, pretty well defined dendrite, and here another dendrite stain with rose Bengal. So rose Bengal stains dead or dying cells, as does lissamine green, which is the substitute we use these days, whereas fluorescein stains areas that have been denuded of the epithelium. So very rare cases, fluorescein will show late staining of metaplastic cells, but by and large, dying or dead cells stained with lissamine green, rose Bengal, and areas denuded of epithelium stained with fluorescein. So in many patients, you will see where the lesion, the dendritic lesion is healed, there is a slight immune response in the subepithelial stroma in the Bowman's layer or just below that, and these are called ghost dendrites, and they are very often a reminder of previous infection. And here you can see this reminds you of the map of North America. So that's your geographic lesion, and then it's associated with a dendrite here, and there's a dendrite here. And this often happens that a small dendrite present and is treated with steroids unknowingly, inadvertently, and it becomes rampant over the surface of the cornea. There's other examples of a large geographic lesion with dendrites extending from it. This patient, you can see, has what appears to be a dendrogeographic lesion, and it is dendrites and geographic expansions. If you put fluorescein and don't look at it straight away, a lot of fluorescein will seep under the cells, telling you that the attachment of the cells surrounding the dendrite is loose. That allows the fluorescein to seep underneath, but you can still pick up the diagnosis. And this was in a patient with conjunctival adenocarcinoma. So even loss of local immunity can lead to the steroid effect, a very rampant spread of the infection of the cornea. This patient was referred to be as a non-healing persistent epithelial defect and also peripheral epithelial, the peripheral ulcerative keratitis, PUK. But as you can see, with these feathery edges, when you see these little feathery edges over there, then you know that this is a dendritic lesion and it wasn't. And then you can see a spur again telling you that there's a tendency for the dendrite to form. So this was the unstained picture with a lot of corneal edema. And here you can see the stained one. So this was also a geographic herpes simplex. In the context of corneal grafts, you will find these dendritic lesions that occur at the graft-host junction. And the reason is because the nerves are all dead. When you cut a cornea, refine it, and stitch it, all the nerves are cut. So the regenerating nerve will come from the host into the corneal graft, and those are the ones carrying the infection from the trigeminal ganglion. So that's why we'll see lesions at the graft-host junction in the early few months even following a transplant. And then you have the neurotrophic keratopathy, which means that the nerves are badly affected, the sensations are poor, and you can get epitheliopathy like this. You see all these different individuals, or you can get epithelial defects. So this is stage 1, epitheliopathy with no defect, and stage 2 when there is a frank defect. So the disease is defined as a disease related to alterations in corneal nerves leading to impairment in sensory and trophic function, with consequent breakdown of the corneal epithelium, affecting health and integrity of the tear film, epithelium, and stroma. Because we're talking about the epithelium, these are the epithelial lesions which correspond to stage 1 and stage 2, or grade 1 and grade 2 of neurotrophic keratopathy. So you must test the corneal sensations. So you test all 4 quadrants: center, top, bottom, right, and left. Direct the patient to look at a distance and then test touch the cornea with a cotton wisp. So away from the line of sight. So as you're bringing it to the patient, bring it straight in the front, you're going to blink. So bring it from the side and gently touch the cornea. Tell the patient what to expect, and then be aware that they might normally blink when you touch. That might correspond with your touch. So do it a few times to be sure that what the blink was not just a coincidence. And you must test the corneal and the conjunctival sensations. And that's very important sometimes, because you will find a lot of patients where, particularly with herpes simplex, the corneal sensations are absent, but the conjunctival sensations are present. So it tells you it's a peripheral problem, not a central problem, like with brain tumor or brain surgery. If the nerve is cut, both conjunctival and corneal sensations will be lost. And the most important point, you must do this before checking the pressure, because once you put a local anesthetic drop, then you can't do it the same day. You have to call the patient back after a few hours on the next day. So this is an example. This is the cotton wisp test. You can do with the Cochet-Bonnet, or there's a more sophisticated Belmonte. Most of us just use the cotton wisp test, draw it to a fine fiber and touch the cornea. And this is an example. So the patient is hardly blinking. You can then see the patient blinks in between. So is that a response to your touch, or was it just a normal blink? So you can see that you touch and the blink is not with that much pressure. The patient would draw the head back, but this is just a little blink. So these are the normal blinks that you should not confuse with the sensation we're trying to test right, left, top, and bottom. So that's you can make the wisp thinner than that, and make sure you've tested the conjunctiva as well. Here's another example where you see this patient has an interstitial keratitis and there's complete absence of sensation. You can touch and rub and very little blink there, but most of this is like absolutely no sensation at all. So this is, of course, a very, very advanced case. We'll just let this video run for the next couple of seconds and then move on. So when you come into the stroma now, stroma largely two types: an immune complex mediated disease. So the antigen is the virus proteins coming from dead or living virus, and the antibody is coming from the serum through the limbal blood vessels. So when the antibody meets the antigen in a certain concentration, in an optimum concentration, they form a complex. The complex precipitates. That precipitates attracts inflammatory cells because it's a very potent chemoattractive, and it forms these immune rings and causes interstitial keratitis and limbitis. So inflammation of a limbus is very, very specific to herpes simplex and to acanthamoeba. So here are examples of immune rings on the cornea, like that. And you might see this, if you dilate the pupil, you see it better. But when you see a patch of infiltration in the cornea or haze, which is right up to the limbus and the blood vessels growing with it, it's called interstitial keratitis. Remember, in these situations, the epithelium might not show any stain at all, but there will be edema of the cornea. So here we treated this. Now, interstitial keratitis, because it's an immune-mediated disease, most stromal diseases are immune-mediated disease. They have to be treated with steroids. But if you don't add or forget to add antiviral agents with it, acyclovir, you can provoke a dendritic infection, which is active viral replication. So this patient ended up with a dendritic lesion because steroids were added without antiviral cover. And the antiviral cover, Dalia will tell us a lot more about it. So these are some other manifestations. All of us see corneas like this, haze, vessels, some less vessels, some more vessels, some defects like that. These are all manifestations of herpes interstitial keratitis. Then we have a T-cell mediated herpes disease, which is either disciform keratitis or the endotheliitis. And here are examples of disciform. So the central corneal edema, you can see peripheral there is normal, and this picture is from Kansky's book. And then you see a lot of KPs, the kinetic precipitates on the back of the cornea where the endothelium is affected. Or it can be a diffuse endotheliitis like this with a lot of KPs all over, and again over a diffuse spread in one patch, unlike the central disciform. So all these are manifestations of the T-cell mediated type of stromal affection with the virus disease. And you can see it's quite deep in the stroma. Now the endotheliitis can occur like a wave. Now this is not well, it is endotheliitis, but not due to herpes. This is a this line of corneal endothelial rejection. But this is how you will see exactly the endotheliitis. It starts as a wave, and it goes right across the cornea. But if you treat it, the endothelial cells that have been infected do recover, unlike in rejection where they're completely destroyed. But if you see a line on the endothelium and it's a rapidly moving line, you see the patient the next day and it's moved from one area to the other, then it is endotheliitis. And then you have this thing called necrotizing stromal keratitis, where you actually get the virus replicating in the keratocytes. So you get very intense infiltration, you get necrosis of the stroma, ulceration and melts, and this virus replication in the keratocyte is active infection and a host immune response. And it causes thinning of the cornea. As you can see here, a very large desmetocele has formed, and dense infiltration, and can rapidly lead to perforation and loss of the cornea and loss of the eye. Or you can get these chronic non-healing defects when it's called metaherpetic defect, when you've got an epithelial problem because of poor corneal nerves that have been destroyed by the infection rather than by the disease process itself. So you get stromal melts, as you can see here. There's a dendrite, but you can see the same patient with very deep gutter in the stroma. And all these things, very vague kind of diffuse appearances you see here and here. You see this one over here. If these patients check corneal sensation, and if it's less, then you can safely attribute it to stromal virus keratitis. Slit lamp, you will see these deep lesions inside. And it causes a lot of thinning, as you can see here, scarring and extreme thinning of the cornea. So this stroma melts, and the epithelium will be intact, but this is stromal necrosis and stromal destruction. And as the dead stroma has been removed by the host macrophages, it causes a lot of thinning. And then finally, these manifestations: vascularization, uveitis, keratouveitis, and retinitis. So vascularization, this point we published, we did a large study, and we concluded that the most common cause of corneal vascularization is herpes virus infection. And the least common cause in the infective conditions is acanthamoeba. You can see severe infection, but no vessels. And here, a lot of vessels, these were all herpes. And the other thing we found was lipid keratopathy, which is leaking of lipid from the vessels which are not very active. They are partially regressed vessels, but they're still circulating blood. This lipid can spread and cause visual impairment. The commonest cause of lipid keratopathy is blood vessels caused by virus keratitis. Blood vessels by other causes do not cause that much of lipid keratopathy. So that's again an interesting thing to bear in mind. So when you see lipid keratopathy in a condition that was not properly diagnosed, think of and check corneal sensation, think of herpes simplex. And these are examples of keratouveitis. You often get hemorrhagic keratouveitis. You get a hyphema, and then you get iris pigment epitheliitis. So the iris pigment epithelium drops off, and the eyes become transluminant. The iris becomes transluminant. And this is the examples of retinitis, which may manifest as vasculitis, as sheathing, as branch retinal vein occlusion, central retinal vein occlusion. You see these sheathing of the blood vessels, which is a sign of vasculitis. And the masquerades are, to finish off my part of the talk, acanthamoeba keratitis can produce dendrites. Herpes zoster produces dendrites. Healing corneal abrasions will produce dendrites. And of course, you get neurotrophic stromal melts, which will appear like. So this is a zoster dendrite. A zoster dendrite, unlike a herpes dendrite, a herpes simplex dendrite is like a groove. The zoster dendrite is lifted above the surface. So that's the difference. But we call it pseudodendrite, but it's actually very different. Only when you know it's zoster, you say it's pseudodendrite. So this is a pseudodendrite or dendrite of acanthamoeba, because they eat the cells and they move along, and you will see that. This is another one you see in acanthamoeba, positive and negative staining, like that. This is in acanthamoeba. And the healing corneal abrasions, when the convex sheets move in, when they meet, this part is like a dendrite, but it's a pseudodendrite of healing abrasions. So bear these in mind. And of course, extensive necrosis can lead to perforation and iris prolapse. This is in peripheral ulcerative keratitis, which you see in autoimmune diseases, but this is for a herpetic disease, where you get a large iris prolapse with melt. And then remember, the stage 3 of neurotrophic keratopathy is stromal melting. So stage 1 was epitheliopathy without defect, stage 2 was with defect, and the third one is melting, and that is also part of many diseases cause it, but very common causes herpetic eye disease. So, in summary, herpes simplex virus can affect all parts of the eye: lids, conjunctiva, all corneal layers, uvea, and retina. The clinical manifestations are very varied and can mimic many other conditions. They are related to active viral infection or due to the immune response, or both. Commonest cause of corneal vascularization and lipid keratopathy and thinning of the cornea is herpes simplex virus keratitis. And this is one strap line I figured for this talk. Never said it before. When it's complex, think it's simplex. So we come back to our question we had asked earlier. The clinical sign of dendritic ulcer is seen in. You can do your poll now. Good. And then the other question, herpes virus replication can be seen in. Well done. So that's good. So I think everybody's got it. That concludes my talk. Thank you very much. So we will now move on to Dr. Said's talk.
Hi, good evening, everybody. So I'm going to give you the diagnosis and management for the herpes simplex keratitis. So we'll start also with a couple of questions, and then we'll repeat the questions again at the end of the talk. So question number 1, dendritic ulcers can be treated with prednisolone acetate 1% eye drops, topical acyclovir ointment, topical levofloxacin drops, or topical gentamicin eye drops. You can start the poll now. Okay, so we'll go again to these same questions again at the end of the talk. So to diagnose hepatic infection, first you've got the history. So when you're suspicious, always ask about a history of previous hepatic keratitis, because it is commonly a recurrent disease. If you have a classic dendritic pattern, especially with the 10 terminal bulbs which stains with fluorescein, then that's very pathognomonic. Always test, as Professor Du has showed you, corneal sensation. So loss or even reduced corneal sensation will give you clues that this infection is likely to be caused by herpes. Now, when do we do laboratory diagnosis? When there is absence of dendrites pattern, especially if the patients had steroids in previously, they were not going to get a dendritic pattern, and they might end up with geographical patterns like you see here. Or if a patient has a history of herpes and he's got new epithelial lesion, but they don't have the characteristic dendritic pattern, and you're not sure whether this is a herpetic infection or not. In contact lens wearers specifically, because the acanthamoeba, as Prof has showed you, can give you a picture very similar to a dendritic ulcer, and often acanthamoeba is missed as a herpetic infection. You don't want to do that and start steroids for the patients. In patients who are not responding or not improving with your antivirals, then that's another reason to go and do laboratory diagnosis. And when you're doing that, you actually scrape the epithelium and send for PCR. And by scraping the epithelium or debridement of the epithelium, you're actually removing some of the viral-laden cells, and that will also help your treatment, not just for diagnosis. And the fifth and last part where you can also do laboratory diagnosis in viral endotheliitis with hypertensive uveitis. So if you've got endotheliitis and corneal edema from limbus to limbus, or even sometimes it's not from limbus to limbus but quite extensive, especially with also raised pressure, and you're suspicious that this may be herpes, then you can do an angiogram TAC and send for PCR, viral PCR, because then once you know the diagnosis, then it becomes very helpful. So when we do debridement of the epithelium or take an epithelial biopsy and send for PCR, the polymerase chain reaction shows sensitivity in 100% of cases. However, it's not very specific, because the viral amplification will happen whether the virus is latent, so previous infections and the virus is latent, or the virus is active. And the way to differentiate is actually by quantifying the amount of of virus, and by the quantification you can tell if it's a high level of infection, then it's likely to be an active infection. If not, then it's latent. And a commercially available PCR can actually give you quantitative results of the amount of viral PCR amplification. But the gold standard is to actually do a viral culture and sensitivity. These tests are usually done within the hospital in the research setup. It's not done clinically as often because it's not very sensitive, although it is very specific, but it also takes a very long time, up to 10 days to come back. Immunohistochemistry less sensitive than PCR or viral antibodies. And it's always good to scrape and for bacteria, and send another sample for histology, because you can have mixed infections. So for example, this patient had also acanthamoeba cysts, which can be seen here in histology. So it's always good not to just test for viral, but test for other microorganisms as well. The confocal microscopy is very useful to differentiate cases where you're not really sure whether it's viral or acanthamoeba, like in this case, where you have a large, looks like a geographical ulcer, non-healing, non-responding, but you do a confocal microscopy and you see these acanthamoeba cysts or double wall cysts, or sometimes signet-shaped cysts, and it all depends on how the microscopy cuts into the acanthamoeba cysts. So if you see these, especially in clusters, and if they're not only in the epithelium but more in the stoma, then that is more likely to be acanthamoeba rather than viral. So the IVCM is very helpful for us to diagnose, and sometimes even before the culture results. It can also show us fungal hyphae, like in this patients, or shows also activated keratocytes and dendritic cells, which are seen with inflammation. And that is also very useful to differentiate viral in some cases. So how do we medically manage herpes simplex? It's a combination of antivirals and steroids, and the whole trick is when to use what and in which quantity. So in epithelial keratitis, epithelial disease, which is a dendrite, you treat with antiviral, either acyclovir ointment, and that is the dose is 5 times a day for up to 2 weeks, sometimes up to 3 weeks, and it should be 5 times a day. So you can't really taper it, you can't really make it 3 times a day, because that is the dose. However, the ganciclovir gel is the other option, and that can be used 5 times a day for the first week and then reduced to 3 times a day. And there is another drug which is trifluorothymidine 1%, and that can be used up to 2 hourly, and that's mostly used in the United States. There are other drugs, but these are the most commonly used drugs. You can use that with or without debridement, and meta-analysis have showed that the debridement can be helpful, especially if the virus is not responding, and it is because you remove some of the viral laden cells, and then you help your antiviral to do its job. You can treat epithelial keratitis with oral acyclovir, 400 milligrams for herpes simplex, 5 times a day for a week. However, we don't add the oral to the topical, so you can use the oral instead of the topical when you cannot give the topical, example like in children or mentally challenged adults. But the oral acyclovir will also work, and you can use it instead of the topical. What about unresponsive epithelial keratitis? So you've given you think it's a dendrite, you've given your acyclovir, and the patient is not responding, still getting and the dendrites are not resolving. So think, is the patient compliant? And ask the patient, because sometimes they say, oh, I put it 4 times sometimes and 3 times sometimes, so not compliant. You have to exclude unrecognized stromal elements, because if that is affected, then you might need anti-inflammatory or steroids, and the antiviral alone will not be good enough, and that will require you to refer the patient to the hospital to be seen and examined properly with a slit lamp. And then also, if you have metaherpetic keratitis due to neurotrophic ulcers, or if you have drug toxicity, because the antivirals can be very toxic to the epithelium, so that also is a cause of unresponsiveness. And the last is the resistance. So we don't think of resistance as a first option. We have to exclude all the other causes before we think of resistance. Resistance can happen mostly in atopic patients or if the patients are immune compromised, and usually happens because of mutation of the virus thymidine kinase, which is required to activate the prodrug acyclovir into a drug which is working. So if there is a mutation in the virus gene, then that will cause resistance. So when you have resistance or you're suspecting resistance, what do you need to do? You need to stop the treatment for 24 hours and rescrape and send for PCR and viral culture. And your options will be to start oral acyclovir at a higher dose, 800 milligrams 5 times a day, or oral valacyclovir 1 gram 3 times for 3 days. Or you can try a different topical drops such as foscarnet, and that can be given 2 hourly for 2 weeks. So we've finished epithelial keratitis. We're moving on to now stromal keratitis. And in stromal keratitis, it is not only infection of the actual stoma by the virus, but also an immune-mediated host reaction to the virus. Therefore, steroids are very important. So we need to give topical steroids, but carefully and under cover of antiviral, because then you don't want to create another epithelial disease or aggravate an epithelial disease which is ongoing with the stromal disease. The steroids should be tapered very gradually, and even after complete resolution of the keratitis, you need to keep the patient on very low dose steroids, for example, alternate weeks, maybe for a month, then twice per week, and then once a week, just 1 drop, and you'll be surprised how much that will prevent further relapses of the keratitis. You can, if you have a mixed infection, delay the steroids up until your epithelial defect heals. So you give the antiviral first and delay the steroids, and then give the steroids later under cover of antiviral. According to the head studies, that did not affect cause of the effect. It delayed a bit the resolution of the stromal keratitis, but had no detrimental effect at 6 months. So for stromal keratitis and endotheliitis or uveitis, you need to give everything, basically. Topical steroids, topical antiviral, and oral antiviral 805 times a day. And if the patient is steroid responder, there are some studies that showed that cyclosporin can be used to reduce the amount of steroid needed in these cases. The problem with recurrent herpetic keratitis is that it is the main cause of scarring and visual loss with herpes. Therefore, it's important to prevent recurrent herpetic stromal keratitis specifically with acyclovir 400 milligram twice a day, which is the prophylactic dose, not the treating dose, and for 12 months, and that is according to the herpetic eye disease studies. The side effects of antivirals are mainly nephrotoxicity. So if the patient's kidney functions are not very good, then you have to reduce the dose of your oral acyclovir. Light sensitivity, some people have GIT symptoms, they can't tolerate the tablets, nausea, vomiting, diarrhea, very unfrequently headaches and dizziness, and blood disorders can be seen with valacyclovir. So we've been treating herpetic eye disease according to a very important studies by the herpetic eye disease study group. And this has been started from the 1996, and they've had multiple publications, and most of us will follow these head studies because they are large studies on large number of patients and have given us quite a lot of insight into managing herpetic keratitis. So 10 points that I will summarize for you that are coming out from these head studies. So one is after resolution of or any form of ocular herpes, you can give the acyclovir 400 twice a day, and that will significantly reduce the recurrence. Number two, there is no statistically significant benefit of the acyclovir 5 times a day for 10 weeks. In treating HSV stromal keratitis, if you're already giving the steroids as well as trifluridine, which is one of the topical antiviral. So if you're treating with topical antiviral and topical steroids stromal keratitis, you do not need to add the tablets as well 5 times a day. So steroids were significantly better than placebo in treating active stomal keratitis. And you can postpone steroids for a while, although it will slow the resolution. However, the outcome at 6 months is not any different. And the advantage is if you have an epithelial and stomal disease, you probably want to give the antiviral alone to help heal the epithelial disease first before you add on the steroids to treat the stomal disease. So if you are treating iritis with acyclovir 400 5 times a day for 10 weeks in patients who are already on steroids and antivirals, they may have a beneficial effect. There is no need to give a 3-week course of acyclovir 5 times a day for patients with epithelial keratitis already taking topical antivirals. That does not alter how much the incidence of stomal keratitis in these patients. Acyclovir 400 twice a day for 1 year significantly reduces the recurrence of both the stomal and epithelial disease, but it has greater benefit when stomal disease. Previous stomal disease but no epithelial disease increase the risk of recurrence of more stomal disease. The number of breast episodes are very important for both epithelial and stomal keratitis, but more with stomal keratitis, and they are associated with the likelihood of recurrence. So the number of attacks means they are more likely to have more attacks. So you want to really reduce them having repeated attacks, and that's by giving the antiviral treatment acyclovir 400 twice a day. Now, psychological stresses have been implicated, sun exposure, contact lens wear, systemic illnesses, all have been implicated in reactivation. However, they were not shown to be statistically significant in triggering herpetic infection. Long-term oral acyclovir significantly lower the recurrences. That is very important, and it is both for epithelial and stomal disease, but more so for stomal disease. That's why it's important for people. We usually tend to give long-term acyclovir for any patient who presents with maybe a couple of episodes per a year. Then we give them long-term acyclovir tablets. Now we come to new metaherpetic or neurotrophic ulcers, which end up after repeated infection. You can end up with a neurotrophic ulcer like this one, and that usually happens because of loss of sensation. So what you need to do is stop all drops, because the drops and the ointments will be toxic. The steroids will not help epithelial healing. You need to stop all drops and use only preservative-free lubricants. And if that doesn't work by itself, you can add autologous serum. We usually make it in a 20% concentration. And there are quite expensive new topical drops such as nerve growth factors, which can help heal these neurotrophic ulcers. If that is not enough, then you can close the lid by taping, or you can use a therapeutic contact lens. But if you have a therapeutic contact lens, remember to give the patient chloramphenicol eye drops preservative-free, because the risk of infection, bacterial infection, increases to 17 times if you have a contact lens on the eye. So if you have a therapeutic contact lens, you always need to cover with antibiotic. And you can increase the lubrication by putting punctal plugs, especially if the patient has dry eye, and that will not help heal the neurotrophic ulcers. And these are examples of punctal plugs, and they can be also canalicular plugs. And the canalicular plugs will not be seen on the surface, so you have to check in the notes to make sure that the plug is there from the nose. When do we resort to surgical treatment in herpetic infection? If you have a persistent ulcer with melting, if you have an impending or actual perforation, and sometimes when you're treating neurotrophic ulcers and the medical and non-surgical measures were not efficient. So that's an example of a large herpetic ulcer which was treated by mechanical debridement and on top of the acyclovir ointment, and with that you remove a lot of the viral laden cells and help heal the epithelium. If you have vascularization like in these patients, then you want to cauterize these blood vessels especially if the patient is going to have a graft, because the vessels can lead to graft rejection. Or if the patient's got lipid keratopathy, then when you cauterize the blood vessel with fine needle diathermy occlusion, then the lipids usually regress. However, you have to be careful because you can get thinning after fine needle diathermy for herpetic infection. And this is the example just to show you how we do this. This patient, so we put the needle along the blood vessel on top or behind it, and we just touch the needle with a monopolar cautery, and that transfers the heat and closes the blood vessels. And in this patient, this is done before doing a penetrating graft for this large perforation that you can see here. Can you see with just a small touch, and you can see that whitening and the blood vessel will get occluded. Very simple technique, very effective. And you have to be careful because you can get quite a bit of thinning after that. But usually, mostly you will see these ghost vessels. So these blood vessels have been already occluded, and you can see them on the way to elimination. And then you can get quite a bit of thinning, and if there is lipid, the lipid will go away. Neurotrophic ulcers like this one, they don't look like a dendrite, as you can see here. They're not infective, but because of loss of sensation, you will see the minimal stomal affection, but this rolled edge of the ulcer, and this is usually very resistant to healing. So one way of treating this is to inject Botox, botulinum toxin, on the upper border obliterator, which is a toxin that prevents the action of acetylcholine at the motor end plate and causes paralysis of the levator and ptosis, like in this patient. And nothing was working. We tried all the topical treatment. Then we put the Botox, and you can see how much the size of the ulcer become much smaller in 1 week, and in 2 weeks it was completely healed. And the advantage of Botox is that you can always lift the lid and examine the eye and see if the ulcer is improving or not. But if it's not effective, then tarsorrhaphy is the gold standard, and most neurotrophic ulcers will heal if you do a tarsorrhaphy, and we usually leave it in place for about a month. Then we remove the bolsters, and we can open the tarsorrhaphy later on. However, people don't like it because it's disfiguring, but sometimes it is the only way to treat these ulcers. And this is an example of a non-healing neurotrophic ulcer, which was the people with a tarsorrhaphy, until you can see here complete healing of the ulcer. Another technique is to use an amniotic membrane transplantation, especially if you have thinning. Then you can put the amniotic membrane in multi-layer and put a bandage lens. Usually we suture only the last layer and put a bandage lens, and the epithelium heals on top of that amniotic membrane. That's an example of another ulcer, neurotrophic ulcer, after infection has healed. And then you can see here with the OCT the area of the ulcer. And we put a multi-layer amniotic membrane, and we suture the last layer, as you can see here. And you can see the ulcer is healed. There is no staining with fluorescein. And you can see the epithelium has healed on top of the amniotic membrane, the multi-layer stacks of amniotic membrane. And then finally, the amnion is taken, and the epithelium is healed, and even the keratocyte starts to lay stroma on top of the amniotic membrane. And this is the patient's final picture. Very rarely we need to use a conjunctival hood flap, so a rotational flap to cover a very deep ulcer which is not responding, where the amniotic membrane didn't work and all other measures have not worked. This conjunctival rotational flap will bring blood vessels and will help very quick healing of the ulcer. If you have a perforation, we use cyanoacrylate to glue the perforation, as you can see here. But be careful, because when you have a perforation, you can still get a reactivation of the virus. Can you see this dendrite on top of the glue? So you have to always remove the bandage contact lens and examine the patient to make sure that you're not getting repeated infection under the perforation, under the glue. And if it's a large perforation, you may need to do a small tectonic graft, like in this patient. And when you're doing a penetrating graft for viral keratitis, you have problems because of the neurotrophic ulcers and the chance of relapsing. So you have to put these patients on acyclovir tablets, long-term 400 twice a day. And you have to be careful with the steroids, preservative-free, and you might end up with neurotrophic ulcers. and you might end up with recurrence like in these patients. And as Professor Du has said, the recurrence is usually at the graft-host junction. So when you get these relapses, then you'll have to cover with topical and systemic antivirals and reduce the steroids. And these are examples of penetrating graft, one with them with, as you can see, a lot of vascularization with a persistent epithelial defect. So these blood vessels has to be cauterized, and you have to reduce the steroids to allow the epithelium to heal. Again, this is a patient where he had a herpes reactivation of stomal keratitis, and he needed to have both systemic steroids and antivirals. Whenever possible, try and do a deep anterior lamellar keratoplasty rather than a penetrating keratoplasty. And we try and use interrupted sutures, not continuous sutures, because then we can, if there are blood vessels coming to certain sutures, then we can remove them. Sometimes the host is very thin, so we have to be careful with the host and graft size because you don't want any leaks. And it's always a balance between the steroids and antivirals and when to increase one on the expense of the other. And very important to look for epithelial disease and manage that quickly, because you don't want the epithelial disease to progress into melting, and it may also trigger a rejection. So again, we go back to questions, the same questions again. Dendritic ulcer can be treated with prednisolone acetate drops, topical acyclovir ointment, topical levofloxacin drops, topical gentamicin drops. Excellent. So it is topical acyclovir ointment. Perfect. And again, side effects of antivirals include nephrotoxicity, hepatotoxicity, ototoxicity, maculopathy, nephrotoxicity. Excellent. Thank you very much. And we'll go back to the questions now. So both Professor Du and myself are here.
Any questions? So, regarding corneal grafting, should a patient be put on antiviral meds to avoid the issue of dendrites from the host tissue to the donor tissue, or would it not make any difference? So, yeah, so when a patient with viral keratitis comes to a corneal graft because of scarring, we always treat them with antiviral medication, because you have to give steroids, as Dalia said, to prevent rejection and balance that with the antiviral. So we tend to give oral acyclovir, 400 milligrams twice a day as a prophylactic dose, and topical steroid drops. So you can put topical antiviral, but they are a little more epitheliotoxic than the oral ones, which are not. So as a new healing epithelium of the graft, you want to insult it less. So the short answer is yes, you must always use a combination of steroids and antivirals. So moving down.
That was the corneal graft one, you know?
Yeah, so
What are the statistics?
What are the statistics for patients transferring from oral to genital herpes to the eyes? So, I don't know the answer of how much, but like we said, 80% are the oral ocular herpes, and 20% of patients have the type 2, the genital herpes in the eyes. So that's the kind of ratio where 20% of people have the type 2 virus in the eyes, but how many from the eyes go down, I don't know. Okay.
After gluing the perforation, what happens? So after we glue the perforation, usually these patients don't have an active viral infection. They end up with a neurotrophic ulcer with thinning, and the thinning leads to perforation. So there is no active viral infection, but it's a neurotrophic ulcer. So what we do is we glue the perforation, and we put always a bandage contact lens and cover with antibiotics. If we think that the perforation happened within an active viral infection, then we cover with oral antivirals. And after about 6 weeks time, when we start to see vessels coming around the glued area and beneath it, then we try and nudge this area of gluing, and we remove that cyanoacrylate disc because it does not dissolve. We have to remove it manually, and then the epithelium heals right on top of it, and it becomes very thin, but it is as long as it is epithelialized, there is no worry. So we take off the contact lens and remove the glue and wait for it. Usually it epithelializes in no time.
So what age group do you see most with herpes simplex keratitis? So there are two age groups when this infection becomes quite increased in incidence. So one is in children, and that is because young children are always cuddled and kissed by adults who have herpes in their lips, and that is how the transmission commonly occurs. And the next peak age group is in the teenage group when they kiss each other and transfer the infection. And they're responsible more for themselves rather than coming to them from adults. So those are the two age groups where it's most, but then once it gets into your system, it stays there almost forever. And are the dendrites in conditions other than dendrites or pseudodendrites? So that's $1 million question. You know, what is a dendrite and what is a pseudodendrite? If you say it's a dendrite because it's herpes, then you've got to know it's herpes before you call it a dendrite. But if you don't know, what are you going to call it? A pseudodendrite? Then everything is a pseudodendrite unless you know it. That's just a misnomer, I think, of pseudodendrite, because it looks like a dendrite. But if you look at the typical dendrite of a herpes, where you have the groove or the gutter, the side branches with the terminal bulb, that is a true dendrite of herpes. But then the dendrite of zoster is different in its physical structure, but it's still a dendrite. Because the name dendrite means something that's linear and branching. So people normally use the word pseudodendrite for anything other than herpes simplex, and a dendrite for anything with simplex. But as you can see, the terminology is confusing, because like I said in the beginning, you need to know what it is before you say it's a pseudodendrite. That normally is not what happens in the clinical scenario. So this one. So the question is, are patients contraindicated for intraocular lens implant surgery and laser surgery if they have had HSV ulcer before?
So it's not a contraindication, but it's the time to the surgery. So obviously, if they need a cataract operation, then we have to wait, and then sometimes we need to cover them with antiviral before. The same for laser eye surgery. If they've had an attack long time ago, then it is a relative, what we call a relative contraindication. It's not an absolute contraindication. And you have to be careful with laser eye surgery because the viral reactivation can happen. So it's quite variable from one doctor to the other who would do it or not. I would personally, if a patient had viral keratitis, I would not do a laser eye surgery.
And I agree with that as well. Do you use any topical antibiotics to prevent secondary microbial infection in severe superficial HSK?
I wouldn't use antibiotics because even if it's severe and it's an epithelial disease, for example, a large dendrite, the patient has not had any steroids or I can't see any evidence of bacterial infection, I will just give the antiviral. and check the patient again in a week and see how he is responding. If he has a mixed infection, so if you've got a little bit of infiltrate, dense infiltrate, then if you're not sure, it is maybe worthwhile to scrape and find out exactly if you've got mixed organisms.
So with this, there's another approach you can take, mentally in your thought process. Whenever a microbial infection is there and you're treating it according to what you think it is and it's not responding, then think of mixed infections, as Dalia said, and check sensations. Now, the other thing about combined bacterial and herpes infection, which does occur, so you will see patients with that, the pain they have is disproportionate to the amount of infection because they may have hypoesthesia because of the virus infection of the nerve. So you may find a patient come with a pretty big ulcer, but is not complaining a lot. That would give you the first suspicion that this is underlying herpetic disease either at present or in the past on which he has got bacterial infection. And that is where you would then start thinking that you have both. But if you're sure that it's only HSV-K, then we don't give prophylactic antibiotics. But where we think it's mixed, then we use it to treat the bacterial component and then the virus component as well. So I think we've got a couple more questions. Are you seeing an increase in ocular herpes infection during COVID? Now, Dalia will tell you about that.
Yes, we are actually. We are seeing, we've published this. We're seeing a reactivation of herpes after the after COVID vaccination in some people. Also, so epithelial disease, stromal disease, and we've had pretty bad cases of herpes reactivation, both herpes simplex and herpes zoster after vaccination.
Yeah, and we see them more after vaccination rather than after the COVID disease itself, and not necessarily only in grafted patients, in any patient. So it is an enigma, and we know that COVID alters the immune system in a very big way. So we don't understand why, but clearly the immune system is being suppressed in some way. One has to postulate for the virus to reactivate, just like with steroids. But here we have an immunological storm happening in the body. So the immune system is anything but suppressed, but still the virus is activating. So it may be that, in some ways the immunity is being altered, allowing the cells from the ganglion to be released. We know that in patients with chronic herpetic disease, where the virus is dormant in the neurons of the trigeminal ganglion, the ganglions are surrounded by a cuff of CD8 positive cells. And it may be that with the disrupted immune system, that protection around the ganglion is lost and allows the virus to be released at the nerve endings into the cornea. So, but the question is very valid, and we are seeing that more and more. So I think we're down to the last question. Is dendritic ulcer patient an urgent referral, and can they start any medication from the pharmacy or wait for antivirals?
No, they have to have the antivirals in most cases. Although epithelial disease can be sometimes self-limiting, but if they have the wrong medications, or they can get worse, and then you can start to get stromal disease sometimes. So I would personally refer these patients to have the antiviral treatment.
Yeah. So I mean, yes, you can send them to the eye casualty, or perhaps in the if you can prescribe it in the independent prescribing for optometrists, perhaps antiviral like acyclovir ointment should be included, so that you can use the acyclovir and prescribe it. If you see a frank dendrite, what's the point of waiting? And there's a case can be made for that. So yes, I think that finishes all the questions. So over to Usman.
Thank you, Professor Dua and Professor Said, for sharing your valuable experience with us all this evening. We really appreciate it. I would also like to thank again everyone who was able to join. We hope to make these webinars a series, periodically running throughout 2022. We will keep you posted on dates and topics. Also, a special thank you to Perceptive Medical Education, especially Martha for all the technical support, and to Rated Doctor again for partnering with Agafa Pharma. We look forward to seeing you next time. From the Agafa team, take care and more importantly, stay safe. Thank you.
Good night. Thank you.